Hello. This is a presentation that I recently gave at Singapore General Hospital in Singapore. I was asked to be a visiting professor and speaker there this past January, and I wanted to share my presentation with you all, and in particular to say hello to all of my friends in Singapore and in the Asia Pacific region. The purpose of this presentation is to talk about innovation in orthopedics and shoulder care, and I want to do so in the context of the environments in which we attempt to innovate, the culture of those environments, and the question of creativity. I want to, in particular, examine how we create value through innovation, not only for ourselves, but for others, and do so with technological advancements as well as innovation in care delivery and in business models. This is particularly relevant to the way we address the major problems facing healthcare in general from an economic point of view and orthopedics. And I'll touch on this particular context in this presentation. Now, Singapore General Hospital is a quite remarkable place. It is the crowning jewel of Sing Health. And I want to present a bit of an overview so the world can understand my impression of a place which I think is a special place. I was particularly impressed by the shared vision of this organization in their statement that they wanted to find tomorrow's medicine and their mission, which is to care, to heal, to educate, to empower, and to innovate, to advance. I'm particularly interested in their motto, which says patients are at the heart of all we do. This should really be the way all of us conduct ourselves in managing our patients and in our own organizations. Now, it's interesting to me because this exactly echoes my approach in all the different steps that I've taken in terms of innovation, whether it's creating organizations or working with companies, and I'll get to that in a moment. This is my LinkedIn profile. If anyone wants to reach out to me, feel free to reach out to me through LinkedIn. I quote Einstein in his approach saying, try not to become a man of success, but instead a man of value. And similar to Singapore General Hospital, I believe the purpose of my career has been to improve the value delivered to all of my customers, really my patients, and all my collaborators in these endeavors. So I want to look at innovation from the standpoint of what Clayton Christensen wrote about in his book, Who Has the DNA to Innovate? This is my background. I've had a number of different experiences that may qualify me to say something about innovation. And my institution's homepage states innovation happens here. Let's examine that and see if indeed that is the case, not just for my institution, but for your institution. My disclosures are that I've been involved in a number of companies around the world as an advisor and developer. Um, I sit on the strategic advisory board of Stryker. I've been on multiple design teams in arthroscopy and arthroplasty over the years, and I am on several boards and continue to be an innovator. I'll touch on a few of these, but that's not really the focus of this presentation. So to start with, if you want to become a better version of yourself, and most importantly, have any approach in innovating, you need to start with the best mentors. And I was blessed in 1990 when I started in practice to work with Dr. Freddie Fu, who was a true innovator, not only innovating himself and creating a unique brand, but in influencing others. And here you can see a group of individuals I worked with at that time with Freddie in 1992. Now, in 1994, you may recognize some individuals here, and let's point out Paul Chang to the left, who was our fellow and went on to become a leading innovator and knee surgeon in Singapore at Singapore General Hospital. We may also recognize Mehmet Demran in Turkey, who became the president of the European Shoulder and Elbow Society, and Andreas Imhoff, who was very influential as a sports medicine and shoulder physician, not only in the East Coast, but many other organizations. Here you can see Freddie to the left on this picture and me to the right. So travel is the best education, and I constantly revisit where I am in the context of what I do by looking at other organizations. And so in 1988 to 1989, I traveled to Europe, and I was lucky enough to meet someone who became extremely important in educating me about innovation and how to be an innovator, and that was Christian Gerber. And if any of you don't know who he is, you should take a moment to briefly explore the impact he's had in orthopedics and in particular shoulder surgery. I also went to the University of Paris where I did some important research in neuroanatomy. And then I went to Linköping University in Sweden, where I worked with Jan Gilquist, who was a leading knee surgeon at the time. In the past 35 years, these are some of my fellows, and I learned that the best teachers are students themselves. And so much of what I've learned over my career has come from the students I've taught, pointing out to me the kinds of questions I should be asking. And to quote E. Emery Codman, who I'll address a little bit more in this lecture, I realized it was the approval of my students rather than my peers, which was of the greatest value. And these here are some of my students, and I'll touch on a few of these going forward. In 2004, in 2004, Denny Lee was my fellow in Boston, and he's become very influential and a very central figure at Singapore General Hospital and was the president of the Asian Shoulder Society. And here we are again in 2022 at the ISICOS meeting when it was in Boston. I also learned that the secret to success is picking good partners. These individuals not only help you in your thoughts and support you, but they make you a better version of yourself. And here's some of these partners: Peter Millett, who many of you may have heard of, fantastic surgeon; Matthew Provencher; Larry Higgins, who now is a leader in the orthopedic industry; and then, of course, Bassem El-Hassan, who is a magician when it comes to management of complex problems of the shoulder. So, how will you innovate? I think what I've learned is you have to ask the right questions and look for the problems that are worth solving. Einstein said if I had an hour to solve a problem, I'd spend 55 minutes thinking about the problem and 5 minutes thinking about the solutions. We do exactly the opposite in our day-to-day functioning in academic medical centers, at least that's my opinion. And Michael Porter, who was my mentor at Harvard Business School, said the essence of strategy is choosing what not to do. We only have so much time to dedicate to our mission of innovation, and we have to decide what are the important things we want to focus on. Now, the world is full of innovators, and this is from a meeting I went to some time ago, and you can see a variety of different individuals here who were chosen to be part of this meeting because of their track record of innovation. On the right, you see Denny Lai, and Paul Chang. And I think the key here is to ask the question, who innovates and what really is innovation? And that's really the focus of this presentation. Now, more than 100 years ago, E. Emery Codman wrote a book on study of hospital efficiency. Can you imagine that? We still are inefficient in most of our academic medical centers. And I'll dwell a little more on him in a moment, but he coined the term the end result concept, which was the predecessor of value-based healthcare. And Michael Porter, 100 years later, continued this on with his seminal work entitled Redefining Healthcare. This cartoon, as you see here, I put in the word value because Codman made that cartoon more than a century ago. Here's Michael Porter and I standing in front of a mural in my office dedicated to Codman's life. And from this, I developed, from my experience with Porter, I developed a value-based agenda. And the key to this agenda was measurement, measuring to improve care delivery, to bend the experience curve and the cost curve, to be profitable by thinking about margin, not revenue, to align with the stakeholders necessary to achieve these goals, to risk stratify so we compare apples to apples, not oranges, to reduce unnecessary care, to integrate care and manage resources as good stewards of those resources, and to learn from others' examples of how to innovate. That's really very important, and you do so by traveling and by connecting with people, and I'll talk about that in a moment. I spent the last almost 3 decades at Massachusetts General Hospital, where I am currently chair of quality and safety in orthopedics and a professor at Harvard Medical School. Now, over here was my office, and the hospital's footprint has since enlarged significantly. I subsequently moved when I hired Dr. El-Hassan, and Dr. El-Hassan now has taken my position there. And while there, I went to Harvard Business School, which will figure into this presentation, and I created several organizations consistent with my mission to create value and innovate. Now I work at our outpatient surgery center, and gosh, it must be about 20 plus years ago that I was one of the four founders of this entity in order to create an alternative to hospital-based care. You can see here the arrow pointing upward is where my office is, and our outpatient surgery center is just one floor above, and we have another one in an adjacent building as well. So let me share with you a few ideas that I have um, applied from my readings and my experience at Harvard Business School. It was the late Clayton Christensen, who was a brilliant professor at Harvard Business School, who said that innovation might be able to be disruptive in healthcare in the way it is in other businesses. And this is a terrific book that he wrote that you should all read. It's called The Innovator's Prescription. And it talks about disrupting healthcare business models. It was written initially in 2008 and subsequently revised. It really is an important reading if you want to pursue what I'm talking about here. Regina Herzinger was one of my professors, and she wrote about why innovation in healthcare is so hard. And she wrote this great book entitled Who Killed Healthcare, which looks at the problems of healthcare, not only in the United States, but other models around the world. And then Michael Porter and Robert Kaplan, who together combined strategy and finance to look at how to solve the cost crisis in healthcare. And they've been very influential in the birth of value-based healthcare in the United States. They look particularly at outcomes and cost. And I want to apologize to everybody outside the United States that the lens which I'm presenting to you is really based on my experience in the United States. And it may or may not be applicable to your own environment, but nonetheless, it's important to talk about it in that context. So if you really want to innovate, you have to innovate yourself first. And to do so, you have to leave your comfort zone. And here I am in the first program I took at Harvard Business School entitled Value-Based Healthcare in 2012. And this allowed me to redefine my comfort zone and continue to educate myself in ways that would scale my impact on value and innovation. I then, in 2015, went and took a executive program entitled Business Innovations in Global Healthcare. Here I am here, and many of these individuals are venture capitalists. That was a different perspective for an orthopedic surgeon. And then finally, I took the full boat approach here and went to the executive program for leadership development, which is an alternative to the typical executive MBA program that one does here. Here I am here with my classmates, and 55% of our group were international. And so I was able to learn different perspectives in business, and most importantly, businesses outside of healthcare, which allowed me to bring some lessons into healthcare that we don't usually speak about. So what are some of the questions that we should address if we want to innovate? Well, let's look at context first, and in particular, economics. If we look at the public and private per capita healthcare expenditure in countries as identified in 2022, you can see the United States leads here with the average cost per person of $12,553. Now, that is 4 times higher than Singapore, where at that time the average expense per capita was 3,000 US dollars. Why is that? And why is it that we don't provide necessarily the best care for the dollar value? So where does the federal dollar go? This is a bit old in terms of the data available, but nonetheless, it's a trend we see, and that is that the federal tax dollar goes principally to healthcare, with 23% going to Medicare, Medicaid, and other healthcare expenditures. And compare that to national defense, which was 19%. Now, that undoubtedly is changing given world events because of the war in Ukraine and in the Middle East. And that will likely come at the expense of not only healthcare, but also education. Then if we look at what do we spend with that healthcare dollar in the United States, you can see here that prescription drugs and inpatient hospital costs lead the list, although outpatient hospital costs are rising significantly, particularly as we attempt to move the care outside of the main hospital, period. Of note is the fact that doctor visits comprise only about 12 cents of the dollar we spend on healthcare. So most of us as caregivers are not the problem, except for the fact that we're the ones that are the stewards of the resources applied to healthcare. And so we determine what costs are applied to each episode of care for our patients. Now, it's really interesting to look at different hospital groups. And if we look at the economic engine of two major academic medical centers, namely the Mayo Clinic and the Mass General Hospital, in the second quarter of 2024, you can see that the operating revenue is exactly the same, but the operating margin is 10 times higher for Mayo Clinic versus the Mass General Brigham. So why is it that some health systems are more profitable than others? And while I won't go into this in great detail, I want to point out there is context here because when you have more money available, you can innovate more effectively without worrying about the bottom line. At least that's my impression. Now, Eric Bricker has a very significant series of talks that he gives, and you can find him on LinkedIn, and I recommend following him. One of his talks really addressed the question of who has power in hospital systems because everything's political and politics is local. So, what he pointed out was that in most hospital systems, it's the orthopedic surgeons, neurosurgeons, cardiologists, CT surgeons, and oncologists that provide the higher margin services and the more favorable payer mix that ultimately cross subsidize the lost leaders in a hospital. So it's logical that these particular departments will have significant impact on the bottom line of decision making in hospitals. In fact, Dr. Lai provided to me this graph, which documents the percentage of surgery performed by orthopedics at Singapore General Hospital. And you can see in 2024, it's 15% of all surgical services. Now, in 2018, I looked at how orthopedics impacted the surgical volume over 1 month at the Mass General Hospital. And you can see here that our impact was 26%. So we figure significantly into the mission and the profitability of our organization. Let's take a step back and look from a 30,000-foot view at the orthopedic industry, looking into the Ortho World Annual Report. And this is useful to understand what is the spend of orthopedics globally and what's the growth rate. So the overall global spend in orthopedics in 2023 was a little over $57 billion, and the annual growth is about 3.5% per year. If we look at the different aspects of orthopedic care that drive this growth, it's not surprising to see the joint replacement is number one. When we consider shoulder surgery, it is reported as a component of extremities, which is not quite $3 billion, but some of this is hidden in sports medicine. And so I would suggest that shoulder, when we combine sports medicine shoulder with the portion of extremities that is owned by shoulder replacement, let's say, and other reconstructive procedures, it's probably around $4 billion annual spend. That's just a guess here. What's interesting is that all the enabling technology that we're now talking about, be it artificial intelligence or robotics, really comprises a small part of the spend in 2022, but will be growing significantly. So here it's a little over $1 billion, and you can see what that entails as well. Now, what about our large academic medical centers? This is old data, but nonetheless, the trend has not changed. How do we see administrators? They're very important for us, but it's also somewhat of a problem for us as surgeons. If you look here at the black line, which is a percent growth in US healthcare spending per capita, you can see the almost exponential rise of spending. And this exactly parallels the growth of the administrative machine, which manages all of our healthcare. And this is consistent with the trend towards mergers and acquisitions, making larger academic medical centers. Look at the maroon color at the bottom, and you can see that the growth of expenditure and the volume of physicians is quite small relative to the growth of these other areas. If you look at income growth, it parallels this exactly with a larger percentage going towards administration and a relatively smaller percentage in the growth of funding for physicians. And again, this is only to 2000, but this graph, I'm sure, has followed the same trend most recently. Now, administrators do have a big problem because hospitals see an increasing cost of care delivery. So if we simply look at the cost of hip replacement from 1997 to 2005, the episode of care is shown here, and the percent dedicated, the percent of which is responsible for the cost of the episode of care of hip replacement has gone from 29% to 61%. So the margin is clearly diminishing for these procedures. And this is exactly what's happening in shoulder replacement surgery as well, although not as much of a reduction in terms of the overall margin. Now, the public trust in healthcare is interesting, and this is from an article entitled Public Trust in Physicians, U.S. Medicine in an International Perspective. And so when we look at the United States, here we are down here at number 24 when one considers what patients feel about the quality of their care and whether or not they trust their doctors. Number one, you see here is Switzerland, and I took the time to look at Singapore, and Singapore ranks exactly about the same level as Switzerland. And when I asked ChatGPT about this, ChatGPT said that this is because of the high trust due to universal healthcare coverage and the efficiency and good outcomes that occur in Singapore. What about evidence-based care? This is an article published in New England Journal of Medicine in 2003 that looked at different areas of care. And as you can see, coronary artery disease leads the list of care delivered with the greatest degree of evidence. About 45% of all patient care is done without accordance in the best practices and best evidence. And frankly, orthopedics and shoulder care doesn't make the list. So if we consider evidence-based medicine, this is a book written by Mohit Bhandari, which is an absolutely excellent book on this topic. And if we consider the hierarchy of evidence from level one randomized controlled trials to level five, which are opinion based, then most of what we do in orthopedics and in shoulder surgery is mostly level five, level four, and maybe level three, rarely level two. And this is why Ioannidis, who is a professor at Stanford, said that most published research findings in healthcare are false, simply because the evidence presented is either fragile in terms of the size of the study or simply wrong. So, what is value? Let's look at value from the perspective of different entities. Value is basically outcome divided by cost. I'll go into this in a little more detail in a moment. For the patient, it's simply the outcome. For the government, it's usually control. And for the insurers and the hospital, it has to do with cost, it has to do with time, and it has to do with resources to achieve that value. And for the surgeon, it's really the outcome and in many instances, the income. When we consider all these factors, if we open the fortune cookie, you can see here the fortune says that wasn't chicken. My personal experience, you can see here in 1984, was being treated for shoulder instability with a half-body spica to stabilize my shoulder in order to make sure that the instability surgery was successful. It was because I had a stiff shoulder and required another surgery to undo the stiffness. That, I can tell you from a personal view, was neither innovation nor was it value. So the problem we have in healthcare, certainly in the United States, and I suspect in other parts of the world, is that we have a lack of alignment between all the major stakeholders. Let's look at that a little bit. This is a multi-directional tug of war. So the patients, they simply want an outcome and they want it to be durable. That's a very important concept that value, as perceived by the patient, is time dependent. Um, the doctor, of course, wants, as I just told you, a good outcome and a good income. And the hospital wants increased access in order to have volume and more revenue. And they want cost containment. Otherwise, they won't be able to deliver their care and remain profitable, which is essential for their mission. The government wants reduced cost and control. The insurance companies want a lower cost. They want to reduce the payments they have to make. And they want to be profitable. And many insurance companies are exactly that. They're for-profit entities. And then the implant companies have a fiduciary responsibility to their shareholders to deliver quality, market share, and profit. So what's the definition of value? Value, as I said a moment ago, is outcome, inclusive of patient satisfaction minus complications, and that's the patient perspective, which is the key. Cost, as defined by Porter and Herzlinger, is very important, and transparency is very important. Now, the key here is how do you measure the numerator and the denominator? Well, as I'll show in a moment, the outcome has to be measured over time. And there is a short-termism in healthcare rather than a long-termism, which is really what the patient wants. And the way we measure the denominator is very much dependent upon the accounting methodology used. Do we use traditional cost accounting? Do we use time-determined activity-based costing or some other method? Many of the accounting methodologies used in major medical centers are anachronistic when it comes to the things that we measure. So if we look at value and price, ask the question, what does industry want, what the surgeons want, and what the patients want and need? I think we'd all agree that fewer complications that come from shorter learning curves will benefit everybody here. Reduce errors in planning, avoiding the wrong surgery and the wrong plan, that creates value for everyone. Reducing errors in surgical execution, including the potential for artificial intelligence and other tools to engineer error avoidance, improving constructs that are better mechanics for more durability, and improving patient experience and lower cost are shared missions and certainly shared purposes. So let's look at a graph here. Value is time dependent, and this is nothing more than a graph of what the patient sees from the standpoint of how they value their shoulder. So if 100% would be a normal shoulder, you can see here the outcome and the timeline for that outcome for primary shoulder replacement, both total shoulder and reverse, as well as revision surgery, and a revision case, as you see here as well in the gray line. Um, in the United States, the 90-day period, that is 3 months, which represents the early episode of care delivered by the surgeon in the hospital, is called the global payment period. And that is where both the surgeon and the hospital are on the hook for financial cost of care. After that, it's the patient that receives all the value. So the question remains, if we have something that we can do for the patient that costs more initially, we may well be stealing from our own margin in order to benefit the patient downstream. And it's very difficult to measure this kind of durable outcome. But cross-linked polyethylene is an example, and I'll show you what I mean in a moment. So what about innovation? This is just off the internet and shows the 12 greatest innovators of all time. And most of you would recognize these names. I find it really interesting to point out to you that number 9 here, Marie Curie, who of course discovered and used radioactivity, was the first woman to be awarded the Nobel Prize twice. So Christensen and colleagues in their book, The Innovator's Dilemma, stated that we know very little about why one person is more creative than another. Let's examine that a little bit. So Christensen was interested in identifying who has the potential to innovate and disrupt. He said that each year 50 million new businesses start. Innovation is the lifeblood of the global economy, and methodology that he used to address this question included an analysis of 2,500 innovators and 15,000 executives in 75 countries. Here you can see some innovators who you know already. Steve Jobs said, "I want to put a ding in the universe." It was Jeff Bezos who said, "You have to be willing to be misunderstood if you're going to innovate," because Amazon was not profitable for a long time. And Elon Musk said, "It's possible for an ordinary person to choose to be extraordinary." So what Christensen and colleagues identified is that about innovation is that it's not a genetic trait, but it's modifiable in your behaviors. They said that nurture trumps nature. So let's look at the 5 key behaviors necessary to really become an innovator. Number 1, you have to question to, quote, puncture the status quo. Number 2, you have to observe with intensity beyond just casual or ordinary observation. Number 3, you have to network to create diverse connections. Number 4, you have to be willing to experiment, which is essential to innovation. And number 5, and maybe the most important, is you have to have associational thinking by linking ideas that are not directly related. Ask yourself in your day-to-day job, working in your medical center, do you have the opportunity to do any of these 5 things? Or are you just so tasked with repetitive activities of care delivery that you don't have time to actually think about this? I think buried in each one of us is the ability to innovate if we took time to spend on doing these things, which Christensen talks about. So the key is, what does your culture allow in your own organization? Now, what you should start doing, if you could, is questioning, observing, networking, and experimenting, because this triggered associational thinking can result in new businesses, new products, new services, and new processes. We'll talk a little bit about where this is possible. Now, Thomas Crummell was the co-director of the Stanford Byers Center for Design and director of the Surgical Innovation Program at Stanford. And I've never met him, but I wanted to share with you an article he wrote in actually the Journal of Pediatric Surgery. You can find out more about this on the Codman Shoulder Society. He said, a scientist seeks an understanding, an inventor seeks a solution, and an innovator seeks an application. He went on to say an entrepreneur seeks independence, autonomy, and control to maximize the likelihood of success in a risky, that is a defined, and an uncertain, ill-defined venture. That sounds to me like a surgeon. He went on to say surgeons ignore technological advancement at their own peril. Now, my professor, Regina Herzinger, wrote this document entitled Innovating in Healthcare, a Framework. And I'm happy to share this with anyone who wants to reach out to me either through LinkedIn or through my email. My best email is jpshoulder@msn.com. She said to be successful in innovation must be profitable, it has to reduce costs and have advocates. It's also important to note that there are different kinds of innovation, technologically based, technology based, integrator based, and consumer based. But there are six factors that affect the success of a new healthcare venture. Number one is the structure. Who's in favor of it and who's against it? Powerful forces can stop an innovation in its tracks. So where you attempt to innovate has a lot to do with the success of your venture. Public policy. What are the local, national, and institutional rules and climate that might allow or block your innovation? Who's paying for this? What about the technology? Do you have the tools available to make this innovation work? Who are your customers? The more, the better. Patients, insurers, the government, other stakeholders. And then what's the accountability? To what degree will you be able to align people through transparency? So to go back to Christensen, he wrote an article entitled Will Disruptive Innovation Cure Healthcare? And he presented some examples. Look at these particular examples. Low intensity portable x-ray machines which cost 10% less than the larger machines. Physician-owned hospitals that are more cost effective than larger medical centers, academic or otherwise. These are cheaper, simpler, more effective alternatives. Outpatient medical centers as well are an alternative to the large hospital systems that can't run lean businesses. And what's interesting is all of these have been blocked politically in the United States to some degree or another, largely because of a variety of other concerns and priorities. Derek Haas, Michael Jelnick, and Robert Kaplan wrote this very nice article about how hospital budget systems hold back on innovation. They went on to say that 800 digital healthcare startups were funded in 2017, and while 75% of senior hospital executives endorsed digital innovation, hospitals were notoriously slow to adopt digital innovations. Barrier number one was unaligned budget units. Barrier number two was rigid annual operating budgets. And barrier number three was separate budget timelines and processes. And I find the same thing to be the case when you try to do multi-center studies or studies across different specialties. The number one question asked is who covers the resources necessary for the cost and time of individuals to work together? That's important when you consider where you innovate. Einstein asked the question, where does innovation come from? And he pointed out that imagination is more important than knowledge. I wonder how many of us can carry this through in our own environments where we work day in and day out. So some of the personal and professional barriers, I think, to being an innovator have a lot to do with where you work. If you are one of these blocks, be it a square or a triangle or a circle, you have to fit in your medical center in the right spot. It is the case, at least from everything I've learned here, that real innovators often find that their shape doesn't fit and they have to find a place where they can adapt or they have to struggle to make the shape of where they work fit them. This was certainly a problem for E. Emery Codman, who published this book on the shoulder, the first book in English on the shoulder. And in the epilogue of this book, he wrote about financial health and your outlook and how it affects your priorities. So in times of plenty, you can see this inverted pyramid here. Patient was the first priority because his ego needs were not as important because he was very successful financially and he had all the resources he needed. But in later times, he had to flip this upside down or back to the regular pyramid shape, and his own needs took precedent over his ability to provide for his patients as the number one priority. So compensation plans matter in terms of giving you the freedom to not worry about, I guess, seeing patients and making money so you can be creative, creating value for others, especially your patients. This is further reinforced by a study published in the Journal of Management that looked at soft and hard models of human resource management. This was a collaboration between the London School of Business and London School of Economics. What they pointed out was that if we look at the soft model and the hard model, this is a opposing view of human nature and managerial control. So you might find the soft model in places like Google and Netflix, which incentivize bottom-up profit generation by innovative changes, which can be scaled into the organization. Academic medical centers, because of the way they're structured, are a hard model that really mostly work from the top down in terms of the structure that they create for innovation and individuals who want to innovate. Harvard Business School looked at so-called strong versus weak cultures. I'm not sure that that exactly correlates with what I just showed you, but when one considers a strong culture being one that fosters innovation, you can see the return on investment here in the blue on the right side compared to a weaker culture, which doesn't focus on a culture that allows for innovation. Now, if we look at the adoption curve of an innovation, where we work has some context, as does regulatory context as well. Innovators are to the far left, and the later adopters or laggards are to the far right. And if we look at different business models in the United States, it's my impression that private groups and privatedemic groups, these are academic private groups, are more to the left, and that academic medical centers and the university settings are more to the right. Now, one may argue with that because in the laboratory there are wonderful innovations created, but in terms of care delivery clinically, I think this is the case, and I'll show you some examples of why. This is an article you probably haven't seen from Health Affairs Scholar, and it's entitled, "Why is it so hard for academic medical centers to succeed in value-based care?" In it, I'll quote some of the points they make. Academic medical centers excel in many ways, but struggle to succeed in delivering cost-effective care and value-based payment models. The reason for this is that much of the underperformance in academic medical centers is because of two core competencies they lack. Number one, limited ability to redesign clinical workflows. And number two, inability or an unwillingness to change their economic relationships with their own specialists. There are a number of key factors here. That includes electronic medical records that lock in existing work patterns, compensation systems that reward volume over value, organizational structure that is problematic for change management, and complex and poor accounting systems. So the reason academic medical centers have this resistance is because they want to protect patients. That's part of the reason anyway. So look at these promising technologies that were adopted and subsequently failed because of what you can see here that is known as Scott's parabola, which is the rise and fall of a surgical technique. There's great enthusiasm initially, and then when the evidence comes out that something doesn't work, there's damage that's reported, and these fall out of favor. This has included arthroscopic thermal capsulorrhaphy, metal-on-metal hip replacement, Vioxx, the drug Vioxx, and intra-articular pain pumps, just to name a few. Now, it takes resilience to be an entrepreneur, whether you're in an academic medical center or outside it. And by that, I mean that every change process requires downgrading first before you can fulfill your best intentions to improve things. So we start out with an idea. We need to look for funding or at least support. We're ridiculed by those who are threatened by the change. There's some degree of despair as we struggle to transform and scale an idea. Then there's some validation, ultimately more funding and buy-in from those who support this. And then there's a new model created, which is basically profitable and allows for survival and growth of the venture. Now, I started the Codman Shoulder Society, which is a group that is dedicated to providing value through innovation and through analysis of outcomes of care. And it was Codman who said, give me something that is different for there's a chance of it being better. Ozan Varol was a NASA scientist, and he wrote in his book, Think Like a Rocket Scientist, something that's very important that affects all of us. He said our tendency towards skewed judgment partially results from the confirmation bias. We undervalue evidence that contradicts our beliefs, and we overvalue evidence that confirms them. NASA scientists do exactly the opposite. We're constantly in healthcare reaffirming our beliefs. So I asked the members of the Codman Shoulder Society to list for me the innovations in shoulder surgery over the last half century that they thought were the most influential and impactful. And as you can see here, number one, not surprisingly, is reverse replacement. This was published in Rockwood and Matson's book in a chapter entitled Framework of Innovation in Shoulder Surgery. And I'll make that available to everyone who wants to see it on the Codman Shoulder Society. You can see a variety of other innovations listed here, but these are ranked in order according to how frequently they were brought up by members of the Codman Shoulder Society. Now, Christian Gerber went on in 2018 to point out the innovations that really were transformational, but we now take for granted, and that's our tendency. Both insurance companies, ourselves, frankly, and the government take for granted many of these, life-changing technologies, including CAT scans, MRIs, and frankly, even reverse shoulder replacement. So if we look at innovation and whether or not it scales or falls, reverse replacement is a perfect example of something that has scaled significantly. And while it didn't follow Christensen's disruptive innovation in terms of providing a less expensive alternative, it has become less expensive over time because of competition. And in that way, it fulfills Christensen's concept of a true innovation. You can see here that academic medical centers often are late to the game here, even if they say they innovate. And I think that that is in order, perhaps, to protect patients, and also because of some of the factors I've already shown you. Now, this graph is from Christian Gerber, and it compares healthcare expenditures and health improvement. On the vertical is the health we improve for our patients, and on the horizontal is the cost of that healthcare improvement. Where we want to really work is in the steep part of this curve where we innovate value. The flatter part of the curve is what I call derivative innovation, or Christensen calls that a sustaining innovation. And the question is, do we create cost-saving technology for the knowledge that we create? Most innovations are really sustaining; they're not disruptive. So, for example, cross-linked polyethylene and reverse replacement were clearly major innovations that dramatically improved health at ultimately lower cost, as I'll show you in a moment. And some examples of derivative innovations are many of the modifications we've made to the reverse replacement that are incremental and sustaining in their degree. They tend to increase cost initially because they're innovations that are new to the market. And that's just the way it works in healthcare until you have competition drive down costs. Now, in order for an innovation to truly scale into the mainstream market, it has to be easier to adopt. It has to involve no major process change. It has to be lower cost and have a high value. And this was the approach written, the philosophy written about in Geoffrey Moore's book, Crossing the Chasm. Let's look at some examples. Most of us would agree that Sir John Charnley, who created the modern total hip replacement, made a disruptive innovation. And William Harris, as well, who basically pioneered cross-linked polyethylene, did as well. Now, what's fascinating about this is that William Harris was in private practice. He wasn't an academic. While he was academic, he wasn't in the mainstream academic medical center structure. And John Charnley made his innovation at a time when the regulatory environment was much less restrictive. You can see here the value, which, remember I said that the value was time dependent. The value of cross-linked polyethylene was in reducing aggregated costs of total hip arthroplasty in the United States by being more durable and resulting in less needed revisions over time. Yet there was a lot of resistance to the cost of cross-linked polyethylene initially. Now, Reinhold Gans was a major innovator in hip preservation in that he discovered femoroacetabular impingement at the end of his career and developed periacetabular osteotomy, which led to modern arthroscopic techniques. He did so with no research, no lab, and no grants. Paul Gromont, as I already pointed out, developed the reverse replacement, and he wasn't the first to think about reverse replacement, but he was the first to develop a sound biomechanical approach. And he was widely disrespected for his ideas. And by the time reverse replacement came to the United States, he had had a stroke and was already aphasic. So, which surgeons have the DNA to innovate? Well, not all innovation is an implant. Many of these innovations came to us at times when the regulatory barriers were lower and hospital barriers were lower. So if we go back to Codman, 100 years ago, he created the first anesthesia record. He created the first book on English and on shoulder, the first tumor registry, and he was the first person to use radiography for fracture treatment. Charles Neer, as many of you already know, pioneered shoulder replacement, fracture treatment, and rotator cuff treatment. And then, of course, Paul Gromont. And frankly, it's not DNA. They had the behaviors to innovate and did all of the things Christensen talked about that I already showed you in terms of being an innovator. Now, the Dominic Meyer Award was founded by Christian Gerber, and it is nothing less than the Nobel Prize for Orthopedics awarded every several years for discovery, innovation, and disruption in orthopedics to honor Dominic Meyer's memory. Dominique was a brilliant thinker and innovator who had an untimely passing from a chronic disease as a young man. The first winner of this award was Reinhold Gans. And look here at the title of his research, Hip Preservation Surgery, Breaking the Rules. He said when he received this award, innovation is barely possible without breaking the rules. He also pointed out, as had Einstein, that curiosity and lateral thinking are more helpful than follow-up studies and meta-analyses, and that teamwork is indispensable to be successful in innovating. So the reverse idea came to the United States from Europe and changed the way we approach things. And remember, I said structure is very important. So those that popularized this, like Gilles Walsh and Christian Gerber and Pascal Bourleau and Mark Frankel, further pioneered with sustaining innovations that scaled reverse replacement into really what it is, which is a major, major advance in the way we care for our patients. So let's consider innovators who change treatment paradigms. This is really disruptive innovation. I've already mentioned some of these individuals, but let's add Masaki Watanabe for arthroscopy, Christian Gerber for all of his concepts in how to treat previously untreatable conditions, Lanny Johnson, who I'll comment on a little bit more in a moment, Charles Neer, Richard Kaspari, who many of you may not know, had multiple patents and created most of the instruments that have since been modified that we use in arthroscopy. And how many of you know Ray Thal, who held the patent for the first knotless anchor that was applied in shoulder repair? Many other innovators like Gilles Walsh and Pascal Bourleau and Joe Ionati, who pioneered the application of digital technology and virtual surgical planning and execution in the operating room, and so many more. And then in arthroscopy, innovating techniques and tools. Lanny Johnson developed the motorized shaver that we take for granted now and use in all our arthroscopy. That was one of his many innovations. Harvard Ellman, Gary Gartzman, Jim Esch, Steve Snyder, Richard Kaspari, Steve Burkhart, and Laurent Lafosse, who pioneered many of the modern approaches and tools that we use in arthroscopy now. So what's in a network? Networking with these individuals and some of the bright minds that are out there now are essential because they allow us to scale our own thinking. And a network's not about building the number of people you meet in a network, but the number of people you introduce others to. It's the power of compounding interest. Innovators grow together and compete with one another and learn from each other. This is a photograph in 1995 of many of the major innovators in shoulder surgery. You can see here Christian Gerber and Gilles Walsh and Pascal Bourleau. And following the 6th Congress of the International Conference of Shoulder and Elbow Surgeons in Helsinki, Stockholm, these individuals in 1995 went on to meet together in the Arctic Circle and do what real innovators do. They all had a high QA quotient, and that means they asked more questions than they had answers for. Again, this is critical if you want to be an innovator. So why do we go to meetings? Many years I went to the European Shoulder Elbow Society. This is the Val d'Isère Advanced Arthroscopy course and the years that it was really in its heyday. Look at all these innovative people here that were willing to travel to learn from new experiences and each other. Gilles Walsh, Evan Flato, Christian Gerber, a young Bassem El-Hassan, myself, Buddy Savoy, John Ticker, who has been central in the development of the American shoulder elbow surgeons. So coming back to where we innovate, it is the case that large organizations generally hire top management teams that are selected for their delivery skills and not their disruptive skills. Established firms simply do well with incremental innovation, not disruptive innovation when it comes to patient care. And we've talked about this already, and this is from the work of others I've already quoted. Smaller organizations tend to select leaders that have skills for disruption. They know how to think different. Smaller firms tend to do better with radical changes that are then scaled to larger organizations. So back to Michael Porter, he said the essence of strategy is choosing what not to do. So what will you do and what won't you do going forward? So let me share with you a few innovations at the close of this presentation. I thought, first of all, after I went to Harvard Business School, that one might innovate the patient care delivery process. I thought if one made it about the patient and not about us, and clearly stated a value proposition based on communication, access, accountability, transparency, care coordination, and critical introspection, will provide better value for our patients. So the Boston Shoulder Institute was what Herzinger would call a consumer innovation, and it was predicated on management and transparency. When you do this, you deliver what patients want, which is basically confidence and reassurance. So every year on our website, we add to our quality measures. We do quality reporting that looks at how fast patients recover. You can see here the different categories that we report on. Every year we report on our own outcomes, including all complications. You can see a breakdown here of the different procedures that I performed in 2023. You can see all the complications that happened that year. We look at our complications. For example, that particular year, I had three readmissions to the hospital, which constituted 0.7% of all my surgeries. We can do cohort analyses, and we have snapshots of the cohort analyses we do based on our patient outcomes registry and patient-reported outcomes. We can measure patient satisfaction rates, as you see here, in terms of overall satisfaction from a treatment, and we can look at why patients are unsatisfied in order to understand how we select our patients and how we manage their complications. And we can also look at how we deliver an exceeded expectation for our patients, how we can make them even more happy. We can do cohort analyses that allow us to look at large data sets to determine how well we're doing and how we can improve. We can measure our complications in order to avoid them. And here's an example with total shoulder and reverse replacement, how we look at complications. So for example, in a cohort of 430 patients, over 4 years, I was able to document that the infection rate was 0.25%. That's significantly lower than the reported standard in literature. We looked at 1,118 surgeries of shoulder replacement and had 3 cases of bleeding, which constituted 0.2% of all of our cases. And we looked at 570 cases and determined that we had only 1 case of an actual implant failure, which constituted 0.18% of all our surgeries. And then we wanted to look at patients who had neurologic complications such as numbness or weakness after surgery, and we looked at 923 patients, of which 33 had some numbness or weakness. Of these, 0% had any residual deficit. So this constituted 3.6% of all surgeries which had a transient, that is temporary, neurologic problem. This helps us look at our learning curve, and there's no question that if you measure to improve, you reduce the time of your learning curve, and your patients benefit from your advanced experience in doing so. We published on this in an article that looked at 100 years of perspective on value from Codman to Porter, and pointed out that articles clearly demonstrate that when we measure, we improve. Porter has called this a virtuous circle of value, and he allowed me to present this. Bob Kaplan pointed out that if you can't measure it, you can't manage it. And if you can't manage it, you can't improve it. And so really this fits with your strategy, because you benefit from becoming an expert in providing better care because you improve the value for everyone, the hospital, the government, the patient, the insurer, by being an expert and having less complications. This gives you a competitive advantage. It improves your outcomes overall and reduces costs. So back to Codman. Codman measured outcomes 100 years ago. So the Codman Shoulder Society wanted to achieve this as well. You see these boxes? These boxes are patient cards that he filed away and took out every time he saw a patient so that he could keep track of how well his patients did and thus change his approach to care. He was one of the first to measure the denominator, that is the cost of care. And he pointed out that if an operation succeeded, the cost was lower than if it failed. We still don't do that routinely in most of the care we deliver. So the Codman Shoulder Society was predicated on his philosophy of give me something different for there's a chance of it being better. And we're a group committed to recording the end result for every patient in order to determine best practices and optimize outcomes in shoulder surgery, just as Codman envisioned 100 years ago. This is a history of our organization. We annually have meetings that look at different things. You can see some of the meetings here. These are all available on the Codman Shoulder Society as they are not only scribed, but also available in video form on ViewMedi. That's VUMEDI, which is a portal for physician education, and also in some cases on YouTube. This is another meeting we had where we looked at the impact of measuring outcomes to deliver value. And I have a blog there, and I regularly report on things that are relevant in these areas, including presentations like this. So this is much more than just shoulder surgery for shoulder surgeons. This is a group we used to meet together and you can see here in 2019 one of our groups that met when we talked about measuring outcomes. You can see in 2022 we met together to talk about value of digital care. We met again in 2023 to look at leadership and career development and entrepreneurial behaviors. Now we mostly do webinars. This was our most recent webinar that looked at value from the standpoint of physician-hospital relationships when it comes to creating value. And we've created a value-based healthcare research group, which is a collaboration between the Codman Shoulder Society and Avant-Garde Health, which is a healthcare data analytics organization. Here's an example of one of our studies. We looked at no less than 151,000 shoulder replacement cases in order to determine what is the most important factor for patient outcome and reducing risk of complication in revision surgery. And not surprisingly, we found that most joint replacement surgery is performed by individuals who do lower volume, as you see on the left side of this graph, and that it is the minority of physicians who are experts who perform most of the shoulder replacement surgeries, and they are the ones that have the better outcomes, as you can see in these subsequent graphs with much lower complication and revision rate for shoulder surgeries performed. And yet, this is not the approach that we take in our care delivery in the United States. Anybody can do a shoulder replacement, regardless of their skill set or regardless of their measurement of outcomes. That, I think, is an ethical dilemma. And here's a scatter plot demonstrating this. So simply, annual surgeon volume affects the odds risk of revision over 2 years following a shoulder replacement. We've also looked at machine learning, concluding that AI tools perform reasonably well in predicting readmission in orthopedic procedures. And there are many others that have done similar such studies. Now, I want to finish up with a little bit discussion of cost. This is a study that we did in collaboration with Avant-Garde Health, where we looked at our own institution at surgeon-related drivers of hospital costs and gain sharing and co-management. And in particular, we looked at surgeon idiosyncrasy as a key driver in arthroscopic rotator cuff repair cost using a time-determined activity-based costing methodology. We looked at almost 700 surgeries performed by 13 shoulder and sports surgeons in 2 academic medical centers. We found that the difference between the lowest cost and the highest cost surgeon was a factor of 6x, and the intraoperative cost of care for the entire episode, that is the pre-op, intra-op, and post-op episode, the day of surgery, was 91%, being the intraoperative cost. The major cost drivers were biological adjuncts like grafts and surgeon decision making, which was rather idiosyncratic. And while additional cost drivers were tendon retraction, fatty atrophy, and number of anchors used, these were not the major factors. And certainly patient age and comorbidity and number of tendons torn did not figure into the surgeon's decision for the resources that they used. This demonstrates the normalized cost, with the inner circle representing the majority of costs and the outliers you can see here, which are likely to be lost leaders in terms of our institution. Now, in another area of innovation, if you look at the digital episode of care demonstrated here in preoperative, intraoperative, and aftercare, you can see that these are the different tools that we may use, be they virtual reality, artificial intelligence, etc. But we tend to ignore education, and education is what really affects the learning curve I just showed you. So let's consider an innovation in education. First of all, what is virtual reality and mixed reality and augmented reality? What's the difference between all of these? So mixed reality are virtual objects anchored in the real world, allowing for interaction with digital images in real time. Augmented reality is superimposed digital technology onto the real world to allow for venipuncture and things like that. And then virtual reality in its true form is a immersive world where computer-generated simulation allows for a virtual artificial environment where we can interact with one another anywhere, anytime with anyone. And it's already in use in other spaces. You don't need a laptop, you don't need wires, you don't need low cost to do this. This is an example of mixed reality, which we can use for referencing in the operating room or potentially navigation. This is an example of virtual reality, which is in just still form here in this screenshot, and I'm going to show you the actual virtual reality that we've used in a moment. It was William Mayo who said there's no excuse today for the surgeon to learn on the patient. So look at this learning experience here at Mayo Clinic many years ago. It was Halstead who said, see one, do one, teach one. But as you can see from before, this affects the learning curve in a negative way. So on-demand education from basic to advanced is now possible using what I believe is going to scale significantly in terms of immersive virtual reality for education. So this is one company that has done this. You can see here in 2 dimensions what really you would experience in 3 dimensions if you were wearing the headset and entering into the virtual reality world. You can walk around this particular cadaver and its anatomy. You can interact with it in ways that are layer by layer, the way that we think about anatomy as surgeons. Here you can see the vessels underneath the muscles. Here you can see the skin applied to the patient. You can start from that point of view. You can look in cross-section throughout the body. You can remove parts of the body in order to be able to see what lies underneath to help you understand the neurovascular anatomy. You can interact with videos that can be linked into live streaming while you operate. And you can work with individuals from all around the world together in a socially connected environment in order to practice surgery with one another. I'm going to finish up with some discussion about artificial intelligence and its role in orthopedics. This is some excerpts from a talk that I gave at the American Shoulder Elbow Surgeons. Jean Chouy, who is the vice president for enabling technology for Stryker, offered these slides to me. So I want to give him credit. I mean, if you look here, today, we work in a world of artificial narrow intelligence where machine learning allows us to do things easier. So we understand Siri and Alexa and Cortana and others helping us in simple activities that we do. Artificial general intelligence will scale this, and that's where we're seeking to go when we interact with patients, not only in the way we take information from them and collect and use that information, but in the way we actually work in the operating room, planning surgery and executing surgery. If you look at the articles published on artificial intelligence in healthcare, you can see on the left side the exponential growth of these articles. Now, this is a bit dated, but if you look on the right side, you can see the application in orthopedics, and in 2021, spine was really the leader. Shoulder surgery here is actually relatively limited. Now, that's scaled a bit, but if you Google artificial intelligence in orthopedics, you'll find over 5 million results. Yet the articles have been lagging behind. Now, an example of artificial intelligence in the way that we're approaching it in one of the ventures we're doing in arthroplasty that you see here, and of course I have a conflict of interest here. We can do virtual reality planning on our patients where you can select a diagnosis and the anatomy of the patient will help AI predict by experts reviewing these, what is the best approach for the patient. This is not yet available, but we're looking at the potential to insert soft tissue so as to look at compliance around the joint, because that will influence our ability to predict range of motion for our patients. Right now, these planning tools simply look at the joint and the bony structure of those joints relative to the deformities that we address with reverse replacement and anatomical replacement. And so it may be possible in the future to make some assumptions about the compliance of the muscles and tendons around the joint. If we do so, we'll be able to look at actual outcomes. An additional thing that we can do now is we can do virtual surgical planning, as you see here, and create patient-specific implants. I want to mention that Singapore General Hospital has a wonderful 3D printing lab that routinely 3D prints joint replacements to help surgeons do their surgery, not only in orthopedics, but in other areas as well. But with this particular model, we can create 3D printed, in this case, base plates to allow for reduction in inventory needs for surgery, which will reduce overall cost of goods delivered for the procedure and may ultimately lower the cost of surgery. And not only that, but the efficiency in moving to an outpatient surgery center where we don't want to have a large volume of inventory in doing our procedures. So you can see an example here of one such implant that we've been able to plan. We can then digitize our plan in order to create patient-specific guides. And in this instance, the patient-specific guide is delivered along with a 3D printed model. And this will allow for a much more efficient preparation of the glenoid without the need for reaming and for placement of the patient-specific implant for a given individual patient. So I'm going to conclude here by asking the question, where do you work? Is your motivation with a carrot or with a stick? This is very much important to how we innovate. It was the management guru, Peter Drucker, who said the culture eats strategy for breakfast. But it was the notorious gangster Al Capone who said you're either at the table or on the menu. Where we work and our ability to control the environment in which we work for in terms of our ability to innovate is critical if we're able to innovate in that environment. Now, I'm going to finish up with quoting Einstein. He said, genius abhors consensus because when consensus is reached, thinking stops, so stop nodding your head. I hope I've raised more questions and answers in presenting this to you. For those who are interested, you're welcome to visit several of our innovations, the Boston Shoulder Institute, the Codman Shoulder Society, and I want to welcome everyone to the 42nd Annual San Diego Shoulder Institute, which was the ultimate educational innovation in shoulder surgery created by James Esch 42 years ago. Finally, I want to make sure that all of you are aware of ViewMedi. ViewMedi is a place where you can look at many different ways to do surgery. It allows you to have video examples, which you can review right before you do a surgery. And in that regard, it's innovative education as well. Thank you for your attention.